Hello, I'm Dr. Marla Shapiro, and I sit on the board of trustees of the International Menopause Society. And today we're going to be talking about prevention and osteoporosis, your bone health. And joining us today is Dr. Mike McClung. Welcome, and can you tell our audience who you are and why you are the perfect person to be talking about this?
Well, thank you, Marla. I am Mike McClung. I'm an endocrinologist and the director of the Oregon Osteoporosis Center in Portland, where I've cared for women with osteoporosis for many years. But our group was a part of many of the clinical studies that evaluated drug therapy and other strategies for preventing osteoporosis in early menopausal women. I have been on the board of the North American Menopause Society and am currently on the board of the International Osteoporosis Society. So I get to think about this question very frequently.
Okay, so let's put this out. Women understand that osteoporosis can lead to a fracture, and they understand about the notion of treating people with osteoporosis. But what's the difference between treatment versus prevention?
Well, the current guidelines, and when we talk about treatment, we wait until a woman has osteoporosis, either by waiting until her bone density reaches a certain low level or that she has a fracture, and then we begin treatment to prevent future fractures. The idea of prevention would be to prevent the loss of bone density and, more importantly, the loss of the bone structure and strength that happens in early menopause, to prevent that from happening so the woman does never gets osteoporosis and never is at high risk of fracture.
So I guess that underscores the importance about preventing bone loss. But why is menopause and bone loss, linked?
Well, with the estrogen deficiency that occurs at menopause, estrogen is very important in bone health. And with that deficiency, there is a phase that lasts a few years where bone loss is more rapid than at any other time in a woman's life. And during that phase of rapid bone loss, there is an actual deterioration in the structure and the architecture of the bone. And that is what osteoporosis is. Osteoporosis is not just low bone density, but it's low bone density in somebody who lost bone to get there. And that's accompanied by this change in bone structure and bone strength. Uh, and we can, once that loss of structure happens, it's almost impossible to get it back. And so it would be more appealing to prevent that loss in the first place rather than trying to rescue the structure in somebody who has osteoporosis.
So, who is at high risk for developing osteoporosis? Who is the woman that we want to identify and think prevention?
Yeah. So we know that the risk factors for having osteoporosis are being thin is probably the most important, and bone density at the time of menopause is actually a very powerful predictor. So women who come to menopause with low normal bone density, that is a T-score of -1 or lower, they are almost certainly destined to have osteoporosis by the time they're in their mid 60s or age 70. Those are women who we can identify as being at high risk for developing osteoporosis. There are many women whose bone density at menopause is above average, and their risk of having osteoporosis in the absence of other diseases is actually quite low. So we can identify quite easily and readily by measuring bone density at the time of menopause who is at risk for having osteoporosis early.
And I think that's important to talk about because many women will not get a bone mineral density as a baseline until they are age 65. So when we look at, let's say, the average age of menopause being early 50s, country specific, let's say 52 to 54, there's quite a gap between that and age 65. So who in those group of women historically, or what women should be looking for in terms of answering the question, am I a woman who's going to be at particular increased risk while my estrogen has now depleted and will always be depleted going forward?
Right. So, numerous guidelines from societies in the United States, at least, recommend that women have bone density testing at the time of menopause if they are thin, and the weight used is 127 pounds, the lowest
Mhm.
quartile of weight distribution. or if they have a family history of osteoporosis, if they've had a fracture, or if they have other medical issues that adversely affect their bone health. But uh, the guidelines from the Menopause Society, from the Endocrine Society, from what was the National Osteoporosis Foundation, all recommend that we consider bone density testing in those women who we know are at risk for osteoporosis.
Right. Certainly those women who may be drink to excess or smokers as well, may be women that we might want to consider.
Sure.
So many women feel, I'm taking a calcium supplement, I'm taking my vitamin D, and I do get some exercise, I'm good to go. No?
I know that we all wish that were enough. And it's important for all of us to feel like we're actively contributing to our health. And all those things are very important for general health reasons. But unfortunately, the rapid bone loss that happens at the time of menopause that sets the stage for osteoporosis is due to estrogen deficiency, not calcium or exercise deficiency. And numerous studies have shown that taking calcium at menopause or exercising more at menopause does not prevent that rapid phase of bone loss.
So many women were put off by the headline news in the early 2000s that still persists more than 2 decades later, and somehow have this mistaken belief that estrogen, is the devil, and estrogen isn't safe, and estrogen, I shouldn't be taking estrogen.
Right.
And I think that really once we re-looked at that data, we're able to tell younger women in the first decade of menopause that this does not apply to them.
That's very important and exactly right. The concerns that the Women's Health Initiative study and other studies showed us was that we shouldn't start estrogen therapy in women who are many years beyond menopause.
Right.
That increases the risk of heart disease. But for women who are never estrogen deficient for very long, that is, who start estrogen in early menopause, then the benefit risk ratio is very, very positive in their favor, not even counting the benefit of reducing hot flashes and other menopausal symptoms.
Yeah, estrogen truly is a bone-friendly drug, and there are so many drugs that are not bone-friendly at all.
Right.
So here's a question that I get asked a lot, and I'm sure you do. I'm in my 60s. I've been taking estrogen since I entered the menopause, let's say 52 or so. When do I have to stop?
Yeah, there's no date or limit to how long estrogen can be taken. As women come back each year and to be reevaluated, we reconsider their whole health picture and situation. And if there are not important risk factors for breast cancer, for example, then there's no reason that estrogen would need to be stopped. However, if estrogen is stopped, it's
Right.
important to appreciate that there's a very rapid loss of the bone benefits within a year or two. And it would be very important for women to be on another bone drug at least for a couple of years to prevent that rapid loss of bone effect.
So I'm hearing two messages that I think we want you to reiterate for the women listening. One is the difference between starting estrogen in an appropriate time and staying on estrogen versus being the 65-year-old woman who comes in and thinks about estrogen for bone treatment.
Yeah. Well, again, that distinction is really important. So, estrogen is ideal for preventing osteoporosis when it's begun early in menopause, where it can prevent that rapid loss of bone density and bone structure, and where the safety in terms of heart disease and other problems is much better in younger women. For women who have osteoporosis and who are in their mid 60s and who have not been on estrogen for many years, estrogen is not recommended, is not approved for treating osteoporosis. And in those women, then we would turn to the other menu of options that we have to treat the osteoporosis itself.
In other words, they've lost that window as to when it was safest to start. And the other message that I'm hearing you say is that should you stop your estrogen, you've pushed that window of the rapid bone loss further along in terms of decades because the estrogen has protected you. But without the estrogen, you'll be like the younger postmenopausal woman without estrogen, and you'll also begin to have a phase of rapid bone loss.
That's exactly right. In the studies we did where women had been on estrogen for several years and then stopped, within 2 years of stopping, their bone density was exactly the same as the women in the placebo group. So all the benefit totally went away. And in the Women's Health Initiative, where estrogen in women at low risk for fracture had a marked reduction in fracture risk, when therapy was stopped, within a year, the fracture protection was gone. So but we can maintain that benefit with 2 years or so of low dose bisphosphonate therapy. I know there's concerns about bisphosphonate and potential side effects of atypical fracture, but those happen with long term
Right.
bisphosphonate therapy. And being on therapy for only 2 years is not associated with significant risks. And then intermittent courses of 2 years of bisphosphonate therapy for the remainder of a woman's lifetime can accomplish total prevention of bone loss in that individual.
Really exciting to be talking about this because we know as women that if we have a fracture, particularly, let's say, of our hip, our risk of ending up in long-term care or
Oh,
ending up not alive within a calendar year is very real. So the notion of treatment is important, but I think what you're saying is let's move the needle back a little bit to really think about how we can prevent this from developing in the first place.
exactly. Even with our most effective therapies, we only reduce the risk of hip fracture by 40 or 50% in a woman who already has osteoporosis. And it would be much more appealing to not have to deal with that and to prevent it in the first place.
Well, thank you so much for joining us today. You've given all of us a lot to think about.
Well, thank you, Dr. Shapiro.